I should have got that thing that you. I think we can start. Good evening, all my dear friends, all my seniors, my teachers. This is our first academic session of Team 2022 ISA Navi Mumbai. So we are a little nervous, and you must have heard some leaked out conversation also. So I apologize if there are going to be some mishaps. Thank you all so much for joining in. Today, February 28th, is a very important day in our Navi Mumbai branch history, because this is the birthday of our very much loved, beloved Dr. Lieutenant Colonel Shiv Shankar sir, who is now no more with us. May his soul rest in peace. So, with fondly remembering him, I would like to start this academic session. My first thing would be to just take you down memory lane, and see the history of Navi Mumbai, how this branch has grown and come to this stage, and from where we would be taking the whole show further. I'm sharing my screen now. Today, I inaugurate this history of our Navi Mumbai branch. Of course, it must be not new for a lot of us, but for our students and juniors who have joined us, this would be a small intro to where we come from. As you can see, these are the two very important documents. On 30th of November 2004, we applied to the national body to give us permission, because as you can see, we were 24 big small villages around New Bombay, and it was very difficult for us to go to Bombay to attend the meetings, various, and for our academic improvement and for help of anesthetists each other, we decided to start this branch. And the permission was granted at the AGM at Bhubaneswar, Bhopal, at the AGM, and our New Bombay was approved. Now you can see this picture. You can see Dr. Shiv Shankar sir, our founder president. This is Dr. Vasumati Divekar, who was and continues to be our mentor and guide throughout. Because of her great contribution to anesthesia and to Navi Mumbai, we decided to name our branch also after in her name. This is Dr. Sureka Patil, who has been, she was at that time the secretary. This is the meeting in progress. This was the first meeting on 11th of December 2004, and hence we keep our branch inauguration day as 11th December, always. This is Dr. Dasgupta. He was from Mumbai branch at Tata Hospital, but he was a great guiding light for us during our birth and during the further growth. The first team was led by Dr. Shiv Shankar sir, with the Vice President Dr. Jagtab and Dr. Nafde, who was then the HOD of Terna. The secretary was Dr. Sureka Patil and Dr. Shantanu Malik, treasurer Dr. Divekar and Chumkawala. And under the guidance of Dr. Das Gupta, we started our club. Dr. Shantanu came up with the logo, as you can see, which became the logo of our branch. Next team to take over, February 2007 to March 2008, was Dr. Jagtab and her team, comprising of Dr. Indula Panchal, Dr. Ruchna Bakshi, and Dr. Gayatri Ramnath. Dr. Divekar and Dr. Shivshankar continue to remain as on the advisory board throughout, giving their advice and guidance. April 2008 to March 2012, again, Dr. Jagtab with a new team of Dr. Mohite, Dr. Anuradha Malliwal, Dr. Rochna, and Dr. Sejal Gandhi took the team ahead. In 2013, much to the work of the 2012 group of Dr. Sureka and Dr. Anita, the society was registered with the Charity Commissioner as a Society of Anesthesiologists, Navi Mumbai, and the PAN card was subsequently made. So now we are very official group. 2012 to 2018 team was run by Dr. Sureka Patil and team, comprising of Sureka Patil, Dr. Anita Roy, Dr. Varsha Vyas, myself, and we had our stalwarts senior teachers as our advisories, Dr. Divekar Jagtab, Dr. Shankar Sir, Dr. Himlata, Dr. Mohite, and of course, Dr. Shantanu Malik, always active. In October 2018 to Jan 2022, Dr. Anita Roy took over, and under her dynamic leadership, we had lots of activities. She was ably assisted by Dr. Varsha Vyas, Dr. Siddharth Verma, Dr. Vaishali Badge, Dr. Reena Gautam, and Dr. Tarin Mittal. And during their tenure, we had the first Dr. V.M. Divekar Orishan by Dr. Bala Venkat, which was in January 2022, which was a huge success. And we're really proud of this achievement. And now my team takes over from 2022. My vice president, Dr. Siddharth Verma, my secretary, Dr. Olvina D'Souza, Reena as joint secretary, Tarin Mittal as my treasurer, and joint treasurer, Dr. Manoj Chauhan. And a very good GC member, Dr. Varsha Vyas, and my executive members, Dr. Vaishali, Shilpi, Sweetie, Dr. Supriya, Monali, and Jay Sheila. During this whole growth, we had a variety of academic activities. Like there was a workshop on mechanical ventilation, symposium on labor analgesia, CME on endocrine disorders, ABG and laryngeal mask AV, Synapse CME on combined spinal epidural anesthesia, ISA sponsored CME, launch of the ISA Navi Mumbai website in 2013, which is very much active, and encourage everybody to go and check out. Pediatric anesthesia, CPCR simulation workshop, topics of ethics in medical practice and stress management, neuroanesthesia and fluid management, and anesthesia outside OT. This is just to list a few. We had many more. Besides that, we also had non-academic social activities. We celebrated World Anesthesia Day every year in some way or the other, either by public awareness, newspaper coverage, or by conducting calls in school, college, and public places. Close it. Close it. So that in short is the history of Navi Mumbai. And on this particular day, I have a very good news to share with you that this is I have a very good news to share with all my friends. This is Mrs. Ragini Shivshankar. She is wife of our beloved Dr. Shivshankar. This is Mrs. Ragini Shivshankar. Today, she has given a check of 1 lakh rupees to start the Dr. Lieutenant Colonel Shivshankar Memorial Award. This is to be used every year to give prizes to our PG students, because Sir was very much for the PG students. And we say a big thank you to ma'am. But she has also given a certain write-up which she wanted me to read out to all of you. So I would just take a small time of yours and read it out to all of you. Dr. Shivshankar is no more with us, but his deep involvement and the long relationship he had with anesthesiology cannot be ignored. He had spent a large part of his life in an operation theatre as a postgraduate teacher and as an avid learner of the subject, associating himself with a wide spectrum of the doyen in the profession. Having served in the army, posted in different locations all over India and being used to a certain way of life, he entered the civilian life with a kind of naivety. It appalled him to see the wicked, wild world of rivalry, money-mindedness, and cutthroat competition. But in quick time, he adapted himself well to his environment, giving himself up wholeheartedly to the task entrusted to him, and that was professor at the Navi Mumbai medical colleges. He was initially at MGM Medical College, and then he moved to DY Medical College. His dedication to his profession was unparalleled, ever ready to allay the fears of the anguished patients willingly, lending a helping hand to his colleagues and a caring and concerned teacher to his beloved students. He always remained a pacifying and calming influence wherever he was. The real cool dude, as Ragini rightly puts it. He loved to be in the company of bubbling young residents who unfailingly reciprocated his tender care and encouraging nature. Perhaps it was this vibrant company that helped him retain that zeal and enthusiasm that he always exuded and kept him young at heart. Attending ISA meets since the mid-80s was a much awaited annual holiday for him. There was no way he would miss it. It used to be around Christmas time till recently, and he always returned refreshed and energized after attending them. He would regularly present papers and in later years be a judge for an academic event, a panel discussion member, or just an eager social animal who cherished the company of many old friends and new acquaintances he met at these huge events. In consideration of all these facts I have known about him, so says Mrs. Ragini, I feel it would be appropriate to institute this endowment, namely Lieutenant Colonel Dr. K.R. Shivshankar Memorial Award, to the postgraduate students of Navi Mumbai colleges. I strongly believe and sincerely wish that his name should thus remain alive in the Society of Anesthesiologists Navi Mumbai chapter, of which he had been an integral part since its inception. Sincerely thanking all of you, Ragini Shivshankar. Thank you, ma'am, so much. This is indeed a great blessing for all of us. So without wasting any more time, I would now call upon my secretary, Dr. Ulvina D'Souza, to carry forth the program. Thank you. Thank you all very much.
Good evening all. On behalf of IAC Navi Mumbai branch, I invite and welcome Dr. Venkatgiri sir, President IAC National, Dr. Naveen Malhotra sir, Honorary Secretary IAC National. They have joined us despite their busy schedule. Pleasure to have you with us, sir. Warm welcome to Dr. Manisha Katikar ma'am, President IAC Maharashtra State. Ma'am is extremely helpful and always motivating. Welcome, ma'am. Welcome, Dr. Shilpa Siviskar, ma'am, Manisha, ma'am, and other state ISA branch presidents and secretaries. Welcome, Dr. Divekar, ma'am, Jagtap, ma'am, Sureka, ma'am, Yedu, sir, for joining the meet. Welcome, Dr. Mrs. Ragini Shivshankar. Finally, I extend warm welcome to all the speakers, chairperson, and participants, and all ISA Navi Mumbai members. Now I request Dr. Venkatgiri sir to say a few words to motivate us. Sir, please. Dr. Venkatgiri sir.
Thank you. Good evening, President Dr. Jesse, National Secretary Dr. Naveen, ISA Maharashtra President Dr. Katikar, Secretary Navi Mumbai Dr. Ulvina, and Madam Divekar, past National President, friends and colleagues. Namaste. I'm happy to participate in this today. Yesterday, maybe it was night, I saw the message of Ulvina asking, are you free to call? It was around 10:40 or so. I was doing a case. I saw the message. I told, okay. She was also live that time. So I told, okay, no issues. Because anytime for an anesthetist, call at any time is okay. Whether it is morning or evening, you receive a call. Why not receive a call of your friend or colleague at any time? If I receive a call at midnight or 2 o'clock, if it is a professional, I take it happily. I should take as a president call of another colleague, whether it is midnight, early morning, if I'm free, I should take that. I told, okay, no issues. Told, can you participate? I told, okay, no problem. Because once you are president, yes, when somebody called that you have to attend a meeting, yes, I have to attend. Otherwise, I should not have become the president. That's my first priority as the president. Thank you. And you are making memory of late Colonel Dr. Shivashankar. I fondly remember my interactions with him in different ISA meetings. Even I remember that elections we fought in Mumbai for GC, where I also got elected for a second time. We had a very good interaction. Many meetings we sat together and talked. And really, it's good that you remember your founder president and have a memory day. That makes me remind that I also should have done this for our past national secretary who was with me for so many years and we lost it. Now I also think that we made it in the Kerala state, but not in my branch. Yes, we have to remember the leaders who are no more with us. That's really great. And I congratulate all of you from Navi Mumbai for making this program. Hope it will be successful. Many people will hear that you have organized a very beautiful talks today by different faculties. I wish all the best. Hope that because of this virtual meetings, we are able to participate from different parts. If it's a physical, maybe I would not have been able to address you or I would not have been able to see you. It is a blessing in disguise, these virtual meetings. Anyway, hope that we will soon have physical meetings, although we may not be able to attend the branch meetings or except maybe state or zone conferences. Really good that I am able to participate. And by the way, Ulvina was telling he was very near to me in Bangalore for 5 years. Maybe I have seen her during that period. I will ask with my urologist who works there about Ulvina and all. Okay, with Dr. Manjunath, urologist.
Dr. Manjunath, yeah, right.
I work with him. Okay, thank you and all the best.
Thanks, sir. Thanks for those kind words. We'll meet soon. Whenever I come to Mangalore, I'll try to meet you, sir.
Definitely.
Okay, sir. Thanks for those motivating words. Now I request Dr. Naveen Malhotra, sir, to say a few words, sir. Please. Dr. Naveen Malhotra, sir.
Very respected Madam Divekar, past President ISA National. Namaskar, Madam. The presiding officers of today's program, Dr. Jesse V, the President, ably supported by Dr. Siddharth Verma, Vice President and immediate past Secretary, Dr. Alvina D'Souza, the Secretary, Dr. Ina Gautam, Joint Secretary, Dr. Taveen Mittal, Treasurer, and Dr. Manoj Chauhan, Joint Treasurer, the GC members and executive members of ISA Navi Mumbai branch, dear Dr. Venkatgiri, President ISA National, very dear and very respected Dr. Manisha Katikar, President ISA Maharashtra. Heartiest congratulations to ISA Navi Mumbai branch for conducting an academic program as soon as the new office bearers have taken over. And they are continuing with the good work done by the previous team led by the past president, Dr. Anita Roy and Dr. Siddharth and Dr. Varsha. I must say that you immediately accepted my suggestion to reschedule it to 7 p.m. because we had our ISA online PG class from 5 to 6:30. So thank you for that. And yes, these whenever any national program is going on, it is better not to have an overlapping city or state program during that time. Very nice. And Navi Mumbai as such is a very vibrant and dynamic branch. And I'm very sure under the able guidance of Madam Divekar and the whole team will do wonders in the coming year. No academic program is successful without the faculty. And I'm very happy that you have a Rohtaki, who is now settled in Navi Mumbai, Dr. Vikram Vardhan, as one of the speakers. He is my college senior. He is alumni of PGI Rohtak, and he will be talking today along with Dr. Monali and Dr. Abhijit. I convey my best wishes to the team ISA Navi Mumbai. Any suggestions from ISA National to ISA National, any advice, any support from ISA National, they are most welcome. And yes, constructive criticism is very welcome. So we are a part of you, and it's happy because of this virtual mode. We are coming here and interacting with you. And I echo the words of Dr. Venkatgiri that yes, it's always better to remember our colleagues whom we have lost, and it's very nice that you are starting an award in the name of your founder president. Yep, I also share with you that ISA National is also starting an award in the name of our beloved editor-in-chief, Dr. Lalit Mandiratta, whom we lost recently. So it will be an award, and hopefully we'll institute this very year itself. With these few words, I once again convey my regards to Madam Divekar, who has been actively contributing to the book which we are compiling for History of Indian Anesthesia. And I look forward to more interactions and inputs from her side. Apart from the photographs which she has been sharing in the groups, some more concrete inputs I'll discuss with you, ma'am, and look forward to your suggestions, inputs, and advice. Thank you very much. Long live ISA. Jai ISCN. Jai Hind. Thank you.
Thank you very much, sir, for those encouraging words. Thanks for joining us, though we are very busy. You readily accepted our invitation. Thank you so much, Dr. Venkatgiri, sir, and Dr. Naveen Malhotra, sir. Thank you. Now I request Dr. Manisha Katikar, ma'am, to say a few words. Manisha, ma'am.
Good evening, everyone. Respected Dr. Divekar madam. मॅडम इथनच नमस्कार करते. तुमच्या आशीर्वादाशिवाय कुठलीच गोष्ट शक्य होत नाही. Respected Dr. Venkatgiri sir, respected Dr. Naveen Malhotra sir, dear Dr. JC and Alvina, dear Dr. Verma, past President Dr. Anita Roy, and my colleagues from Maharashtra State Chapter ISA team, Dr. Shilpa Divaskar, Dr. Manisha Ghosh, and many of my dear friends who have joined this online meeting from Navi Mumbai. Welcome to you all. For this new team who has taken the task of Maharashtra, taking ahead of Maharashtra State Chapter ISA activities with a new zeal. Dr. JC and Dr. Alvina, I must congratulate you. The day you have joined ISA Navi Mumbai, you are continuously asking us, and in fact, I must say, Dr. Naveen Malhotra sir, they are waiting for the program on 15 to get more and more involved with the ISA activities. The 15th March program, know your, or in fact, know our ISA. So they are eagerly waiting. And I must congratulate JC madam, the enthusiasm with which you have joined the team of Maharashtra State Chapter ISA is really encouraging. I wish all the best to the new team. Whatever work the past team has done, Dr. Verma and Dr. Anita Roy has taken Navi Mumbai ISA to a greater height. Dr. Varsha Vyas has equally supported them in all the activities. My respected fatherly figure, Dr. Dedu sir is there with you all in the team of ISA Navi Mumbai. Wish you all the best. For any support from Maharashtra State Chapter ISA, we will be always there. Thank you very much for inviting me here on the prestigious dais of ISA Navi Mumbai.
Thank you so much, ma'am, for those kind words. I can say Manisha ma'am is very cheerful, active, and so energetic. Feel we get all the energy from her to organize more and more activities. Thank you so much, ma'am, for all the help, motivation, and everything, and all the help, ma'am. Thank you so much. Now I request Dr. Divekar ma'am to say a few words, ma'am. Divekar ma'am, please. Ma'am, you have to unmute, ma'am. Divekar ma'am.
Varsha, can you unmute her, please?
Yes, ma'am. Yes.
Please unmute her.
मॅडम तुम्हाला अनम्यूट करायचंय दिवेकर मॅडम. अनम्यूट करा.
Can you hear me now?
Yes, yes.
Yes, ma'am.
Okay. So, good evening, and Dr. Venkatgiri, Dr. Malhotra, Dr. Manisha, and all members of the new Jesse, Surika, and all of the members of the Navi Mumbai branch, and also whoever else is watching. Actually, I have been in the ISA Navi Mumbai branch from its birth. In fact, I have attended most of their meetings since their inception. Is it 20 years ago? Or 20 years ago, is it? Yeah. Anyway, the branch has been very active, and we had many meetings and academic as well as other meetings and entertainment wise. And of course, Dr. Shiv Shankar, I was also closely associated with him, with the branch, and also personally. So it's sad that he's not with us anymore. And I think I wish the Navi Mumbai branch, Jessie and her team, all the best. And I'm sure they will do a great job. You've already started greatly. Okay. So wish you all the best, and God bless you all. Thank you. Okay. Yeah.
Thank you, Divekar ma'am, for encouraging us. We need your blessings always. Thank you so much, ma'am.
Okay.
Now I request Dr. Sweetie Purushottam to conduct the academic program further. Dr. Sweetie Purushottam is working as assistant professor in D.Y. Patil Medical College. She has done her fellowship in regional anesthesia and pain medicine. So over to you, Dr. Sweetie.
Hello, everyone. I am very happy to welcome you all, giving a fresh welcome to everyone and our esteemed patrons of ISA to our very beautiful city of flamingos, that is Navi Mumbai. So being a part of the new ISA team, which is led by Dr. Jessie ma'am, Dr. Olvina ma'am, and Dr. Mithal sir, they wanted to pursue the academic energetic vision that Dr. Shiv Shankar sir had. So in his memory, we are privileged to host this session, and our monthly academic meet, it is directed towards encouraging more learning as well as sharing of the knowledge that is there among all experts in various areas of anesthesia specialty. So we need more participation as well as newer ideas, as well as understand that all kinds of cases that we do, the clinical knowledge is the foundation as well as the main center of our practice. So here in this monthly academic meet, clinical skills are the focus area that we are trying to bring on and bridge among our specialty members. So let's move on to the session that we have planned today. There will be a very slight difference in the schedule. We will begin the talk with pathophysiology. Before that, let us welcome our senior anesthesiologist who will be moderating this entire session for today. That is Dr. Swati Diware ma'am. We welcome you, ma'am. She is a dynamic personality who has been professor of MGM Medical College until 2017, and she has also worked in various other institutes of Fortis Hospital, MGM Hospital, and currently she works at Reliance Hospital. She has also been part of Lokmanya Tilak Medical College, and her very special interest lies in most of the areas of anesthesia, but having her fellowship done in regional anesthesia from Ganga Coimbatore, she is more inclined towards orthopedic surgeries and orthopedic related anesthesia. So we welcome you, ma'am. And our first speaker is actually going to talk about pathophysiology of abdominal aneurysm so that we have a better understanding of the case presentation for today. I'll be welcoming our first speaker, Dr. Monali Babiska, who also has been a very dynamic personality. She is a table tennis player. She has also been involved in acting, singing, and other than that, her educational qualification has been from LT Sion, Mumbai, also BARC Hospital. And she also has been a private practitioner after being an assistant professor from MGM. So I welcome you, Dr. Monali. Kindly take over.
Good evening, respected madams, sirs, and dear friends. Most anesthesiologists at one time or other saw the anesthetic management of patients with aortic aneurysm who underwent surgical procedures other than correction of aneurysm with or without the prior knowledge of the existence of the aneurysm. Today, I'm going to speak about the pathophysiology of aortic aneurysm. Diseases of the aorta are most often aneurysmal. Definition of aneurysm is local permanent dilatations in the aorta. The normal size of the aorta in male is 2.1 to 2.5 centimeters. In female, it is 1.9 to 2.3 centimeters. Ectatic aorta is when the length of the dilated segment is more than 50% of the diameter. The size in male is 2.1 to 4 centimeters. In female, it is 1.9 to 3.5 centimeters. Aneurysm is when the diameter of the dilated segment is more than 50% of its length. In male, it is more than 4.5 centimeters, and in female, it is more than 4 centimeters. The values are more by 1 centimeters in above 60 years of age. Classification of aneurysm is according to shape and the site. According to shape, it is fusiform and saccular. Fusiform is when there is a uniform dilatation involving the entire circumference. Saccular is when there is an eccentric dilatation only. According to the site, it is thoracic and abdominal. Thoracic is most common places the ascending aorta within the few centimeters of the aortic valve. Abdominal is suprarenal or paravisceral or pararenal or infrarenal, which is the most common site. Pathogenesis is the primary event is the adventitial and medial elastin degradation, also called as elastolysis. Embryology basis is the thoracic aorta, the cells are derived from the neuroectoderm and the mesoderm, and the media consists of approximately 60 units, which are vascular and avascular. That is why the thoracic aorta is better suited to withstand the higher pulse pressure. Whereas the abdominal aorta, the cells are derived only from the mesoderm and not from the neuroectoderm, and the media consists of approximately 30 units, which are totally avascular. That is why abdominal aorta is more prone to aneurysm. Progression of the aortic aneurysm. There is a tear in the intima of the vessel wall due to forces of the luminal blood pressure, leading to aortic dissection. Blood surges through the tear in the false lumen, separating the intima from the adventitia. This causes the origin of the side branches arising from this portion to get compromised, leading to ischemia of the end organs. The aortic dissection, which is long-standing, further leads to aortic rupture. The blood stagnating in the aneurysm also can cause thrombosis, which later on can cause embolization and DIC. Signs and symptoms of the aortic aneurysm, most common is the patients are asymptomatic. Some patients can present with as a pulsating mass on auscultation or palpation. Some patients can present with a bruit, and some patients can present as an impingement of adjacent structures like hoarseness, stridor, dysphagia, dyspnea, plethora, aortic regurgitation, or congestive cardiac failure. The signs and symptoms of aortic dissection are acute onset of sharp migratory pain along the course of the aorta, increase in systemic blood pressure with vasoconstricted peripheral vessels. Some patients can present with stroke, myocardial infarction, gastrointestinal or renal ischemias due to compromised blood supply to the adjacent origin branches. The signs and symptoms of aortic rupture are the classic triad of hypotension, backache, and pulsatile mass. But these are present only in half of the patients. Almost half are asymptomatic. Some patients, depending on the size of rupture, can present with hypovolemic shock and sudden death. Now, etiology, the causes can be divided into hemodynamic, biochemical, metabolic or genetic, infectious or mechanical. Hemodynamic cause is the most common is the systemic hypertension. Biochemical causes are aging, more than 60 years of age, smoking, atherosclerosis, third trimester of pregnancy, 4 to 6 times more in men than in women, more in whites than in the blacks. Metabolic or genetic causes are the bicuspid aortic valve, Ehlers-Danlos syndrome, Marfan syndrome, family history, which has got a 13% prevalence and 25% prevalence in brothers, tumor growth factor beta receptor 1 or tumor growth factor beta receptor 2 mutations, genetic defects in collagen and fibrillin, cystic medial degeneration of the aorta, and Lewis-Dietz syndrome. Infectious causes are chlamydia, pneumonia, and syphilis. The mechanical causes are aortic coarctation and operations on the aorta or severe blunt trauma to the abdomen or chest. Most common is the deceleration injuries due to automobile accidents. The diagnosis is based on the clinical signs and symptoms, X-ray, USG, which is highly sensitive and specific, CT with contrast for the size estimation, MRI for the relevant vascular anatomy, especially the dissections, echo with color Doppler, transesophageal echocardiography, and iotography. Now, the predictors of risk of rupture are the diameter more than 6 centimeters, rate of expansion 0.5 centimeters per year, tortuosity, less tortuous, more the risk, cross-sectional diagonal asymmetry, more the asymmetry, more the risk, smoking, which is directly related to the number of years of smoking, female, 3.9% per year compared to 1% in males with the same size. The size of the thrombus, symptomatic patients, patients with family history, patients with chronic dissection, and with persistent hypertension. Now, the perioperative management is the aim is to prevent rupture or dissection. Patients are advised moderation of physical activity. Also in the OT, we have to, there should be a moderation of physical activity, surgical or endovascular repair according to the rupture risk to the patient benefit ratio according to the associated diseases, normalize the blood pressure with ACE inhibitors or beta blockers, angiolysis, cessation of smoking, treat the dyslipidemia with statins, adequate hydration, anticoagulation if there is a presence of atherosclerosis or thrombus, and regular screening of size and anatomy at regular intervals. Periop monitoring is, the main monitoring is closely monitor the systemic blood pressure, central venous pressure or the pulmonary artery catheterization for volume status in patients with congestive heart failure, previous MI, and surgeries which involve the major extracellular fluid or blood loss expected. Echocardiography monitoring for cardiac and aortic monitoring with the patients with predictors of the rupture risk, urine output and temperature monitoring. Now, what should we do if there is aortic rupture? Patients who are with stable vitals, the resuscitation is deferred as the clotting and tamponade effect is lost with increasing of the blood pressure. Patients who are unstable, they have to be taken for immediate repair with volume resuscitation. Thank you.
Extremely good presentation, Monali. I
Thank you,
must
ma'am.
congratulate you. You have covered almost all the points. Can you tell us what is pseudo aneurysm?
Yes, ma'am. Pseudo aneurysm is actually, it is not a pathology condition. It is iatrogenic, mostly it is iatrogenic due to the catheterization of any vessel. There is a breach in the intima or the media layer, but the vessel wall per se is normal. There is no disease of the there is no dilatation or anything like that. It is a pure dissection. The blood collects in the blood collects surrounding the vessel. So it is like it looks like a aneurysm. It looks like an aneurysm because the blood is collecting between the intima media and adventitia. So it looks like aneurysm, but there is no dilatation of the vessel wall.
All the layers of wall are not involved in that.
In the aneurysm, all the three walls are intact.
Yeah. Okay.
Thank you, ma'am. Any other questions can be added on the chat box, or we can take it at the end of the main case presentation. Dr. Olvina, ma'am, we'll move on to the next speaker.
Yeah.
All right.
Sure, sweetie.
Yeah. So today's star of the monthly meet is Dr. Vikram Vadan. He is a professor at Divai Patil Medical Institute, and he has been very enthusiastically pursuing cardiac anesthesia. He's done his training from AIMS Kochi, also been part of PGI Chandigarh faculty at Mahe Manipal, and also been very dynamically been the founder at ACTRACT Tata Memorial Hospital, which was established here in helping them set up the ICU. And he's always been a wonderful teacher, guiding students whenever they have any doubts, and at the same time very down to earth and friendly with even the other staff. They don't he doesn't differentiate. He makes working a fun place, even though it is cardiac anesthesia that he manages. So the case that he will be covering is an elderly patient with cardiac and also other multiple comorbidities. And let us move forward and see how and what is so interesting part about it. So over to you, sir. We welcome you.
Thank you, sweetie. I think these are really sweet words from sweetie. And before I start my presentation, I say there are so many firsts today and so many repetitions are also there. Repetitions means I'm very closely related to Navi Mumbai, who was also in PGI Chandigarh. Then I think our Venkatgiri sir, he was there in Bangalore, and we shared certain platforms together in the ISA Bangalore. And of course, all the people who are there, many of from different institutes, they are together here. And many firsts are there, that this is our first meeting of the new management committee. Then with Shiv Shankar sir, I was associated because when he was HOD in the MGM Medical College, that time we started the cardiac department, and I happened to be the first person to do the case there. That's a young person with the ASD. That time we had a lot of discussions, plus and minus, and he has helped a lot in very ethical and logical way. And I, of course, thank all the participants who are, I can see around 58 in number. Recently it was 60 plus, who has given a good start for this first meeting. So coming to my slides, just give me a minute. Yeah, you can see the screen, I hope so. Hello, can everybody hear me?
Yes, we can hear you, sir. But the
and you
screen
see
is
the screen?
No, not yet.
I have made it in the large screen. So once I put the share screen, it should come in the.
So have you opened your presentation?
Yeah, presentation already opened. See here is the presentation.
सर नीचे शेयर स्क्रीन का ऑप्शन है, उस पर क्लिक कीजिए.
मैडम उसी पे मैंने क्लिक किया, शेयर स्क्रीन पे क्लिक किया.
तो करीब
स्वीटी को होस्ट बनाओ, उनको को होस्ट.
हाँ,
सॉरी,
को होस्ट बनाओ उनको, तो शेयर कर पाएंगे.
अच्छा,
ओके, नाइस टॉकिंग.
हेलो.
hello, hi madam, I can hear you.
Dr. Vardhan, sir, you are already a co-host. Please try
Okay.
sharing it again.
Okay, I'll just go to the share screen once again. It is showing me different screens, but what the, yeah, I got it now. Thank you. Now you can have a look on that. I hope
Yes,
so.
we can.
Yes, yes.
Okay, so it's just a casual call from the surgeon, and surgeon happened to, I can tell the secret, Dr. Monali's husband, Dr. Arun Babiska, with whom we have attached last more than 10 years or so. And he told that, sir, we have got a case and we're supposed to do the intra-trochanteric fracture, but I request you to have a look on that. So patient is having the multiple comorbidities as Sweetie is 92 years. And he was, apart from the fracture IT, he was already in case of anemia. He was having hypertension, then diabetes and chronic kidney disease. And he was also diagnosed abdominal aortic aneurysm around 3 years back. And he was offered the treatment in different hospitals, but the family refused it. कि बाबा को साहब 90 साल हो गए हैं, जितना झेलिए अपना ठीक है, हमको रिस्क नहीं लेना. But now this was a sort of emergency, so we had to deal with the patient. So as I told, he had a history of fall at home and fracture right femur, intertrochanteric, and he had the anemia. It was 6.3 was the hemoglobin, and it was investigated and found that it was iron deficiency anemia. So he was given the iron IV before the surgery. Then he was given the pack red cells preoperatively. He was having hypertension. For that, he was on amlodipine 5 milligram BD that was continuing, and diabetes were very much controlled with the HbA1c of around 6.2%, and he was having 150 to 200. And he had the chronic kidney disease that was recently diagnosed, but the creatinine was just around 2.3, 2.4. So it was dialysis. And as I told, abdominal aortic aneurysm was present, but they have refused for the treatment. Let me show you some of the investigations. See, this is his profile that the pus cells were also present that were controlled by the antibiotic, that is the peptides. And then this is the 2D echo. So he had a mild compromise, that is 55% ejection fraction, but vessels were okay, and mild aortic regurgitation that we can just ignore, and other things were okay. So we can say Babaji bilkul 90s ke bilkul fit the, otherwise from the heart point of view. And then, as I told, hemoglobin was 6.3, and we have given the 2 PRBC before the surgery, and there was a just borderline total counts, and ESR was high probably because of the consisting diseases what he was having. Then to confirm the diagnosis, the ferritin and the vitamin B12 levels were also done, and the physical treatment for that was going on. And lipid profile was absolutely normal. Then he had the MRI because he was having probably little bit of neurological derangement, but except that mild changes, nothing was specific. So ill-defined, some glial tissue was there. The renal function test, he was having blood urea 101, and creatinine earlier it was 2.3, then it rose up to 3.03, but input output was maintained. And other parameters were okay. Potassium was slightly on the higher side, 6, and chloride was okay. Calcium was slightly on the borderline. Then along with that, he was having the hypoproteinemia. Around 6 was the total proteins, and 3.1 was the albumin. And the PTNR that was around 1.4. This is the routine examination that I can skip that. This is the say what he had the ultrasound. So it was showing that a large abdominal aortic aneurysm was seen on the left of the aorta, which was measuring 10.8 into 8.3 into 8.3, quite big size. What Mona has helped me a lot by telling me all the details. Thank you. And it was approximately 395 cc. The neck of the aneurysm was measuring 7.5 mm, and it shows the flow also was there. And except that, nothing was raised, and slightly raised renal cortical echogenicity because of the chronic kidney disease that he was having. And other than that, it was okay, simple renal cysts were there. So now say what is to be done? We have optimized the patients by giving the PRBC. We have taken the high risk consent both for the anesthesia as well as the surgery. And the patient was having two sons. Both were taken into confidence and they have signed on the paper. And we had the backup of the ICU with ventilator, with the hemodynamic monitors, and cardiologist again from our own Navi Mumbai Hospital, Dr. Ninath Iotic, and intensivist, of course, me plus one more intensivist. And we had a backup of the CVT surgeon that if needed, he can come immediately, though he was not in the campus, but he was available within 5 kilometers. So that was the pre-optimization was done. Then let us consider what are the pros and cons of the regional anesthesia and general anesthesia. Regional anesthesia, as many of our senior colleagues, they know that earlier for the spinal or the epidural, we used to give the lateral position. And patient is supposed to be एक मामा उसको पकड़ेगा, ऊपर से सिर को दबाया, नीचे से पैर को लिया, एकदम first class position देगा और spinal आ जाता है. But in this particular patient, we cannot do that because patient is having aortic aneurysm, and any pressure on the aneurysm that can increase the chances of rupture. So we have to keep the sitting position. Then blood pressure changes, two types. One is the low, second is anesthesia. This can have a low blood pressure, which can be managed. And in this case, I have given the phenylephrine 2 times, 50 microgram each, and because that will keep the pressure around 10 to 15 millimeters of mercury will increase, but the heart rate will be same or there will be very mild increase. If the blood pressure is kept on the higher side, then it can lead the chances of aortic aneurysm rupture. And so in all the cases, positioning of the patient during the anesthesia as well as during the surgery, we should avoid the pressure on the aneurysm. And since we had 2 surgeries of the patient, one was that said they have tried the catheterization of the patient in the pre-op phase, but they could not pass because patient had undergone 3 years back the prostatectomy. Because of that, uterus stricture was there. So now the first urologist, they were doing the endoscopic guided catheterization. In that, what happens that we have got the 2 theaters. Once the urologist does the procedure, then all it is wet and a sort of very difficult for other people to do. And secondly, the lithotomy position is usually done, but in this case, what we have done, the lithotomy was there, but it was very, very, very low lithotomy just to make the entrance point for the surgeon. And after doing that, we have shifted the patient to another OT. So the time was here constant because I have to give the anesthesia. Then after that, we are shifting the patient, and then we are giving the position for the orthopedic procedure. The general anesthesia, the positioning here is not much of the concern, except say that same lithotomy is there, same lithotomy here, and in the orthopedic procedure, it will be on the left lateral. But what happens, the blood pressure changes are there during laryngoscopy and intubation, and that are very, very difficult to predict how much it will go. And if we are giving the anesthesia, general anesthesia, the doses of the anesthetic agent should be cautiously given and should be given in the graded doses so that both hypotension and hypertension can be avoided. So considering all these factors, that if we are giving the GA, it will affect the other organs also in the 92-year-old patient. So I consider that I'll be giving the regional anesthesia. So I have given the epidural L4-5 level, test dose of xylocaine with adrenaline, 2%, 3 ml was given, and the place was confirmed. After that, spinal anesthesia was given, L3-4 space with 25 gauge spinal needle. 2 ml was given, with the T9 to T10 level was achieved. And after 1.5 hours, when I know that now time is there, another 1 hour is remaining. That time I have given the epidural anesthesia, 0.125% bupivacaine with fentanyl 2 microgram per ml. I started with 2 ml and went up to 3 ml. And since the patient was having low proteins plus INR was on the high side, I have given the FFP 2 units and PRBC 1 unit. And with that, we have monitored the patient for ECG with ST segment, because that's quite important in this patient who might have the ischemia at any point of time if the patient is under stress. And the sedation was given only 0.2 milligram midazolam, that's all. No fentanyl, no other drug, because I have thought that this patient, the minimum is maximum. NIBP, of course, respiration rate, saturation, temperature, and input and output. And we had the warmer also available. In the postoperative phase, same monitoring was continued. Epidural anesthesia was going on, and 2 points of PRBC were given on separate 2 days, one on the next day and then one after that. And after 24 hours of surgery, epidural catheter was removed. So to summarize this, the successful outcome depends on, one is the pre-operative optimization of the patient from different sources like the physician, then the urologist, then the antibiotics, and then general build-up of the patient, and giving the other drugs like hypertension control, then your diabetes control, and meticulous intraoperative and postoperative monitoring. And of course, it's a teamwork that includes the surgeon, the urologist, the staff, nursing staff, and everybody. So I again thanks a lot to all the office bearers and my teammates. Thank you very much for giving me this opportunity. And I hope I kept the time of 10 minutes that was allotted to me. Thank you.
Thank you, sir. Dr. Swati Diwari, ma'am.
Vikram, I must congratulate you for doing such a difficult case and successfully, and in managing it so very well. I would like to know certain things. First of all, how did you pre-operatively manage the patient? Like, what did you do pre-operatively? Because there are certain things. First thing is anemia. For that, you said they were giving her iron. So how old was the fracture? Was he in the bed for a long time?
No, this anemia was long standing. That was going on for last 3 months or so. So before the surgery and before the fall, they have been giving the
okay. I was wondering whether they were giving iron even after the fracture.
No. And then the surgery, the fracture was 4 days old. They have taken the 4 days to give the plasma, to give the PRBC, and to control any infection, because urine was having some infection inside, if you have seen. So that antibiotics were going on, and there was no temperature, and other things were okay. So after that, we have taken the patient.
Okay.
Thank you, madam.
Since he's one more thing, since his aortic aneurysm was diagnosed beforehand, so was he on any antithrombotic agent?
No, he was surprisingly having only the aspirin going on, 75 milligram, nothing else.
Only aspirin, nothing else.
Only aspirin was going on. That is probably because of the hypertension also, and maybe to help in just the anticoagulation. That's all.
Okay. So there was nothing. I mean, you didn't have to do any bridging for this. Not take him on.
No. Bridging is usually done when we have said that.
Or what? Was they giving anything for 4 days? Yeah.
Yes, madam. Only 4 days it was there.
Okay, so they had not given any antithrombotic agent during those 4 days as well?
No, madam. Only aspirin was going on. That was before the fall.
Okay, and what did you do for the potassium? That was 6. So was anything done for that?
No, they have given the patient calcium, and they maintain the good input output. And when we have done the last report 1 day prior to that, it was coming at 4.9.
Okay.
Because the nephrologist was also involved in the team. He was taking care of that part.
Okay. One more thing I want to ask you, what can you do to make patient comfortable for giving spinal? Can you do something for that?
Comfortable in the sense,
like you said, you must have given him in a sitting position, right?
Yes, madam. So sitting position, I have given him the pillow, what generally we do. And I have learned a lot from you also in the MGM regional procedures. So just make the patient sit down comfortably. And luckily he was very lean and thin person having around 60 kg body weight, and he was around 170 centimeters of the height. So I did not have much of the problem. Just I told the mama to hold the patient, and then he was cooperative, madam.
Okay. I would suggest you can give even femoral nerve block for making him sit up for the giving spinal and epidural, since you are going to give him epidural as well. So even giving a femoral block is a good idea in that case, that
Yes,
patient
madam,
can sit comfortably for a longer time.
Your
That
point is well taken, but the here issue was there that two surgeries were simultaneously. Had it been only the fracture femur, I could have probably given that, but they had to finish the urological surgery, and after that they were going to take that. That's why I chosen the spinal epidural.
Okay, and I was just wondering why the urology procedure was done before that. Like, is it possible to do something else, like just put a guide wire and thread a catheter over it, and when you finish everything, then you can do a definitive procedure later on? Because here you had to shift the patient from one OT to another OT, as well as you have to give a lithotomy position. Moving a fractured femur patient so much, I would really get scared. What do you say?
That is the point taken. But what has happened that the urologist previous night to the surgery, they have already tried the things on the patient's bed with their local jellies and all, but it was not possible. They have put the dilators, they have tried to put the guide wire, but over guide wire, there was no place for the other catheter to go. So that's why they have taken that on with the surgery, main surgery.
And what is the risk involved in the moving a patient who has a fractured femur?
Yeah, fracture femur say as such what is there, that one part is the bleeding, but bleeding is not much, and patient may have a very remote sense of the thromboembolic phenomena.
Yeah.
So for that we had the continuous oxygen going on for the patient, 1 liter per minute, and we are monitoring the oxygen saturation continuously. These two monitors were being done intra.
Okay, very good. And
you,
one more thing I wanted to ask you. You said you gave spinal anesthesia in L3, L4 and epidural in L4, L5. Is there any particular reason for giving the spinal in a higher place? Usually we give it in a lower space. So I was just wondering whether the lower space was not available or something of that kind.
No, nothing like that. It was like surgery was done on the lower limb and the perineal area. So when I'm passing the catheter, I pass the catheter downwards rather than the upwards.
Oh,
so that was the reason I have given the L4, 5 space, and L3, 4 space I have given the spinal electively.
Okay. Good one.
Thank you, madam.
Okay, and bupivacaine also, which you gave later on, the top-up dose, that also you gave only 0.125%. Was that enough?
For the
surgery,
person,
you had to give it for the surgery.
The requirement comes down, and the spinal was working till the end of the surgery. Okay. So just before the end of the surgery, for a prophylactic reason, half an hour before I started, because it was already around 2 hours.
Oh.
So that will take care of the level, madam.
Okay. Very good. Yeah.
Thank you, madam.
Thank you, Dr. Vadan sir and Dr. Swati ma'am. The discussions can go endless whenever there's a case presentation in anesthesia, because we are always very curious to know the approaches of each practitioner and how they've done the case. And as we all know, the human body is one, but there are various approaches, and it's always very interesting as well as a learning experience to each one to know what tricks and methods of management has been used by another person, no matter what age of experience you are in the field. So there's a small bite about Swati ma'am that I'll tell you. She's also, despite having 34 years of experience in the field of anesthesia, she has found time to balance it on the other side of life. She's a great writer, singer, and also won lots of accolades and awards in acting. Very inspiring, ma'am. The kind of work-life balance that you have, and especially still continuingly motivating young generation in the field of regional anesthesia. So that's hats off to you. Now we will move on.
Just a minute, Dr. Sweetie, there is some question in chat box. Can you just take the question, if possible?
Dr. Vardhan sir,
Yes.
Dr. Anita wants to know the duration of the procedure. How long did the procedure last?
It was 2.5 hours, madam.
Okay. And was there anything that was planned post-operatively regarding? So we will move on after a really good discussion on this highly risky patients. There's one more question on ropivacaine heavy, if there's any opinion on that usage. Vardhan sir? Vardhan sir? Is
Hello?
there?
He is
You hear me?
muted, I think.
Yeah, yes. Ropin, I am not very comfortable because I am not new to the Ropin. I am using conventional Anavin that I am using for last 25 years or so. So I'm more comfortable with that. But some people who are using Ropin, they are giving the excellent reviews. Then another question is not giving only spinal. Only spinal, madam, I don't know how much time they will take for the surgery and how long my spinal will last. That is part one. Part two is that for the post-operative pain relief, I wanted to continue the epidural anesthesia in the post-operative phase also. Yes, INR was 1.4. INR 1.4, we have given the patient FFP before the surgery, and then we have given during the surgery also 2 FFPs were given.
Dr. Vikram, did you
Yes,
consider
madam.
giving unilateral spinal?
No, madam. Because unilateral, what we are telling, theory, it's okay. We can give unilateral spinal, but there are two issues are there. One is that say it is usually not unilateral. It is preferentially on one side. That is part one. Secondly, they are going to do the urological surgery in the first part. So for that, I have to give them the both sides. And the thirdly, to give the unilateral, I have to make the patient lie on the left side, that is the injured side. So lying on the injured side is very difficult. The fourth point is that since patient is already having the abdominal aneurysm, the moment we flex the patient's body, there can be chances of rupture because of the pressure increase on the aneurysm. These 3-4 reasons are there.
Yeah.
Anyway, thank you for your great interest.
Since somebody has asked about the ropin, I would, like
yeah,
to
please.
have some discussion on isobaric bupivacaine, if somebody has some experiences. Since I see Dr. Shilpa and Dr. Rajesh Rao here, so if they can enlighten us about that, we'll be grateful. Dr. Shilpa?
Ropivacaine heavy is a good molecule, especially in such patients. I've used it in about 30-40 patients so far, more than that maybe. And good hemodynamic stability, duration is also good. Only thing is, some people have felt that there is less of motor effect, more of sensory, but I have not noticed that much. All my surgeons have complained about it. Isobaric preparation again is a good molecule, but again, motor loss versus sensory motor, those things are there. So for such cases, which should be sure shot, I would prefer to use the conventional time-tested bupivacaine, and maybe as one somebody said, unilateral spinal is a very good option. You need not give the spinal in unilateral. You can give it in sitting position safely and make the patient turn on his side after giving the spinal immediately with a hyperbaric.
Thank you very much, sir. We appreciate.
Thank you. Thank you, everyone. We will move on to the next session. It is by a final year resident of MGM Medical College, Dr. Abhijit Thomas. He will be talking about the drug tranexamic acid. So whether it's our ticking time bomb of abdominal aneurysm, iotic aneurysm, or any hemorrhagic areas of injuries or surgeries. This one drug is synonymous, so we need to cover it alongside. And the main idea about this academic monthly meet was to provide a platform for our budding young postgraduate students who would also be involved in bringing about the different various areas of the specialty. So I welcome you, Dr. Abhijit. Kindly take over.
Thank you, Siti ma'am.
Yeah.
Good evening, everyone. So the topic for today is tranexamic acid. Before we start, we'd like to just take a quick this refresher for what is the coagulation cascade. So here we have a schematic diagram of the coagulation cascade showing the intrinsic and the extrinsic pathway. And also down below, we'll see how the tranexamic acid works by inhibiting plasminogen, which then will help inhibit fibrinogen from converting into fibrin and fibrin split products. So here is another diagram. On the left side is what normally occurs when fibrin binds to a lysine binding site on plasminogen, and this with tissue plasminogen activator, they form fibrin degradation products. On the right side, we'll see how tranexamic acid binds to the lysine binding site on plasminogen, and this prevents fibrin from binding to plasmin. So this will not help in production of fibrin degradation products. So chemical properties: tranexamic acid is a synthetic derivative of amino acid lysine. It exerts its antifibrinolytic effect through the reversible blockade of lysine binding sites on plasminogen molecules. So when come to pharmacodynamics, the antifibrinolytic effect results from the formation of a reversible complex of the drug with plasminogen. It completely blocks the interaction of plasminogen and the heavy chain of plasmin with lysine residues of fibrin monomers. So primarily through its binding site, through high affinity lysine binding sites of plasminogen. Saturation of this site prevents binding of plasminogen to the surface of fibrin. This process retards fibrinolysis because although plasmin is still formed, it is unable to bind to fibrinogen or a fibrin monomer. It is 6 to 10 times more potent in terms of binding to plasmin than the other synthetic antifibrinolytic agent, epsilon aminocapric acid. So when you come to pharmacokinetics, maximum plasma concentrations are attained within 3 hours of an oral dose. Elimination after an IV administration is tri-exponential, and over 95% of each dose is eliminated as unchanged drug in the urine. Of the total amount in circulation, 3% is bound to plasminogen. The drug crosses the blood-brain barrier and the placenta, but excretion into the breast milk is minimal. When you come to therapeutic uses, it's used in cardiac surgeries for perioperative treatment, mostly commonly as an IV loading dose of 10 mg per kg, followed by an infusion of 1 mg per kg per hour. This results in a significant reduction in postoperative blood losses. For acute upper GI bleeding, reduction of blood transfusion requirements is seen in patients with upper GI bleeding when given tranexamic acid. For gynecological uses, efficacy is in the control of bleeding has been reported in individual patients with placental abruption or postpartum hemorrhage. Neurologicals, a randomized double-blind study in patients with subarachnoid hemorrhage showed significant reduction in bleeding in those who received intravenous 6 grams of tranexamic acid per day for the first week, and thereafter 4 grams per day for up to 4 weeks. Other uses: for dentistry, short-term dental surgeries in patients with severe bleeding disorders such as von Willebrand factor deficiency or hemophilia A, we can give tranexamic acid. Inherited bleeding disorders also, like inherited angioedema, hereditary hemorrhagic telangiectasia, and hyphema. It is also used in recurrent epistaxis. So you come to the dosages. A dosage of 500 mg to 1 gram by slow IV injection 3 times daily, or 1 to 1.5 grams 2 to 3 times daily orally is recommended for local fibrinolysis. Patients undergoing cardiac surgery are given IV 10 mg per kg dose before cardiopulmonary bypass and an infusion of 1 mg per kg per hour thereafter. An IV infusion of 10 mg per kg before release of tourniquet may be used in patient undergoing knee arthroplasty, and treatment with oral 6 to 12 gram daily for 4 days has been used in patients undergoing transurethral prostate surgery. Women with menorrhagia should receive 1 to 1.5 grams 3 to 4 times daily orally for 3 to 4 days. The contraindication for tranexamic acid is in patients with a history of thromboembolic disease. Dosage reductions are recommended in patients with renal insufficiency. We come to a case report seen in 2011. It was published in the Saudi Journal of Anesthesia. It was described an accidental intrathecal administration of tranexamic acid in a 30-year-old male in a patient posted for arthroscopic knee ligament reconstruction under subarachnoid block. They observed that high doses intrathecally causes massive sympathetic discharge with an initial hypertensive response and ventricular arrhythmias. So the symptoms described by them were tingling numbness in the back and lower extremities, respiratory depression, myoclonic jerks to generalized tonic-clonic seizures. The treatment provided was supportive, and the airway was secured and mechanically ventilated. The myoclonic jerks were treated with clonazepam 1 mg and phenobarbital 800 mg stat dose. GTCS treated with IV sodium thiopental 3 to 5 mg per kg. Patient developed ventricular tachycardias after 10 to 12 hours after the accidental intrathecal dose, and that was treated with IV amiodarone 10 mg per kg for 24 hours. The mistake was promptly identified and treated, so hence neurodeficits were avoided. Once the patient's GCS improved after 3 days, the patient was safely extubated. So on the left side, we can see the previous, how the tranexamic acid ampule was there compared with an old ampule of a bupican heavy. And now after the this increased incidences of accidental intrathecal administration, they have now color-coded the bupivacaine heavy ampules. These are my references. Thank you.
Thank you, Dr. Abhijit. We are welcoming questions from everyone present here in the chat box. Dr. Swati ma'am, would you like to discuss anything?
No, I think he has covered everything. And
ma'am, your mic is under mute.
No, I think he has presented everything properly, and good that he showed that the two ampules, how they can, look alike, and what will happen, what happens when the tranexamic acid is injected in subarachnoid place. Really a scary incident, but good that the patient recovered. Should we have some more discussion about the case then?
Yes, madam, I want to make a comment on that.
Yeah.
The dose of the amiodarone actually 10 milligram per kg is quite on the higher side. Usually what we give is that we are having 3 ml ampoule containing 150 milligram. So it is 3 milligram per kg body weight given over a period of 20 to 30 minutes with strict monitoring of the ECG, heart rate and blood pressure. And after that, if it is needed, then we can give an infusion of 600 milligram in 24 hours in 50 ml series. The direct dose of 10 milligram per kg is very high, single dose, usually not given. You can say 3 milligram per kg and then remaining around 6 to 7 milligram per kg over a period of 24 hours. And if needed, we have to support the patient blood pressure also. Okay. Thank you, Abhijit. It was a good presentation.
Thank you, sir.
There is a question from the guest here. What is the experience of Tranexa use in TURP? Your mic, Dr. Abhijit. Yeah.
So TURP syndrome can cause some bleeding sometimes. Tranexamic acid given 30 minutes before the procedure is very helpful in minimizing any bleeding. So we can give 500 to 1 gram. It should be given slowly because tranexamic acid given in a fast bolus can cause sudden hypotension. So it should be given over 5 minutes. So it is very helpful in giving in patients for TURP syndrome.
Thank you, Dr. Abhijit. We wish you a very grand success ahead in your life once your final exams are done. I know
Thank you.
I'm really happy that one of your interests is chronic pain, which I really support in. Also critical care. My wishes are to you, and also every other faculty who has been guiding you would be happy to see you here.
Thank you.
And I welcome Dr. Jessie ma'am to felicitate Swati ma'am for Jessie ma'am.
Yeah. So
Atam.
so just like everything is online, even our felicitation is online. So thank you very much, Swati. This is our token of love.
I'm accepting it. And thank you very much, Jessie.
Welcome. Thank you.
I got it and I liked it very much. Thank you.
The hidden goodies are in the boxes.
Yes, yes. I'll be distributing to everyone afterwards.
60 people are here.
Okay, sweetie, you can take over.
Yes, also the speakers, we are very thankful, and Jessie ma'am also extends her felicitation to you all three. Dr. Monali Babiska, Dr. Vikram Vadan sir, and Dr. Abhijit Thomas.
Yes.
Thank you for coming here and putting in your viewpoints and management ideas. So a brief about Jessie ma'am, a very enthusiastic fitness and dance that she is into. Also, she has been academically involved in MGM Medical College as associate professor. Before that, she had a stint as in private practice, so she knows the pros and cons and what all happens either side. So she is one person who has been very generous in putting forth newer ideas. Also, her interest lies in pediatric and obstetric anesthesia. So we are happy to have various aspects in our new team. And the next session will be vote of thanks by our secretary, Dr. Olvina D'Souza ma'am. About her, she is a professor at MGM Medical College in Navi Mumbai, and she has over 35 publications to her name. Now, her interest is in difficult airway, and also we very happily involved in a lot of academic activities for her PG students and improving the area of interest in our city branch. We welcome you, ma'am. Kindly take over. Olvina, ma'am?
Yeah. Thank you, sweetie, for those kind words. First and foremost, I would like to thank Dr. Venkatgiri sir, President ISA National, for joining us in a short notice despite his busy schedule. Like I said, when I called him yesterday, he was doing cesarean section at 10:30 p.m. He readily agreed. Thank you, sir. Thank you very much. Express my heartfelt thanks to Dr. Navi Mumbai, Honorary Secretary ISA National, for attending and motivating us. I also express my gratitude to Dr. Manisha Katikar ma'am, President Maharashtra State ISA, for all the support and encouragement. I would like to thank Dr. Shilpa Tiviskar ma'am, Dr. Manisha Ghosh ma'am, and presidents and secretaries of other ISA branches, Dr. Divekar ma'am, Dr. Vaswani ma'am, Dr. Varsha Vas ma'am, Dr. Anita Roy for active participation and guidance. And I also thank Mrs. Ragini Shivshankar ma'am, Dr. Priya and Anand for instituting an award to the deserving anesthesia PG students of Navi Mumbai in the name of late Dr. Lieutenant Colonel Shivshankar sir. I thank Dr. Jessie Vanel, our dynamic president, for all the efforts. She has put a lot of efforts in this academic event. Thank Dr. Sweetie for their wonderful anchoring, and all the office bearers, for the efforts taken in organizing this clinical meet. I would like to thank all the speakers, Dr. Vikram Vardhan, Sir, Dr. Monali, Dr. Abhijit, and Dr. Swati Divre for that wonderful discussion. Thank you, Dr. Swati. I also want to thank all the ISA Navi Mumbai members and all the participants for joining the webinar and for active participation. Finally, I want to thank ISA Maharashtra State for providing technical support and Janika for the same. Thank you all. Thank you all for joining and for the active participation.
Thank you, everyone.
Thank
There's
you,
a small note. Dr. Rajesh Rao has also given a hint that he would prefer fascia iliaca compartment block in positioning for the patient. So that's one additional point he wants to share here.
Yes, I agree to that. The even a simple femoral block also will do for giving position of the patient, and even post-operatively you can have femoral with lateral femoral cutaneous and obturator block or a pain block for the pain relief later on in case there was no epidural. And one more thing, I just forgot to ask whether that was bipolar hip replacement was cemented or non-cemented, Vikram? I think Vikram has disappeared. No problem.
Likewise, ma'am, the discussions will be endless. We have every month.
Vikram Vardhan is there, but he's muted, I think. He's there.
Dr. Vardhan, sir? I guess he might have.
Ma'am, it was cemented.
It was cemented. Okay.
Yes, ma'am.
Starting on the cementing procedures. But luckily, patient did not have any reaction. I kept the hydrocortisone ready, Avil ready, and Dexuna ready. Plus, of course, yes. Thank you, madam.
Can I say something, Swati? Procedure goes long with an LMA or something. This is my personal choice, but I was
Your
just,
point is well taken. Just let me RBC. After that, it settled to 1.08, and then we have taken the decision to give the epidural.
Okay, you didn't mention about that info.
Yeah.
Okay, thank you, Dr. Vardhan.
Okay.
Thank you, Anita madam.
Thanks.
I think we can conclude. It was wonderful.
And Dr. Vikram Vardhan has assured us, taking us for party.
Yes. Very soon we would have a physical meet. Till then, we plan to have a clinical meet online every month as far as possible. This seems to be more convenient because we can do it without much expenses.
Yeah. So whoever is interested in participating and present any cases can approach us. So
we would like
to plan accordingly.
Yeah, this would be purely clinical case presentation followed by a discussion. Yeah. So most welcome. Please contact Secretary Dr. Ulvina.
Yeah,
Thank you.
Hello, Jessie, can you hear me?
Yes, ma'am.
Yes, ma'am.
Yes, actually it was a very nice CME and wonderful it was.
Thank you very much.
And congratulate you on its success.
Thank you, ma'am. Thank you so much.
And you are looking cute today.
Thank you, ma'am. Thank you.
Okay.
Thank you.
Okay, dear.
Thank you. Thank you, ma'am. Okay.
Okay.
Thank you. Thank you very much.
Thank you.
Yeah. Good night. Good night, everybody.
Good night, everyone.
Good night.
Thank you.
I didn't see Siddharth. Hello.
Siddharth was busy. Siddharth had his OPD, so he has sent his wishes.
Okay.
And, he will be joining us in further meets.
Okay, meetings. Okay. Okay, then bye.
Bye.
Bye, everyone.
You,
wonderful.
Bye, everyone. Good night.
Yeah, good night.
सुरू झाला सुलत ना सुरू झालं का हा माझं झालं नाही हे थोडंसं राहील
संपला बेटा क्लास तर ही सर